just so that these are the cards that we're going to share with everyone, anyways. But thanks for having us to present at the Noon conference. Um, as we were sort of discussing with many of you as we round on a daily basis, there was always sort of this question: is like some clarity on what transplant listing looks like, what are the hemodynamic criteria that allows individuals to get listed at a particular level, and the nuances of listing. And I thought it would be a good avenue to not only sort of go over that, the reason behind it, and then share the actual metrics themselves, just so that you are aware of them. And not until a question is like, what are we looking for on these hemodynamics that we do on 4 times a day basis? So I won't go through bore you through the details of the transplant. I think it's a whole talk in general, but just focusing on the allocation system itself for transplant, it has evolved over the years. Back in the day, it used to be sort of relatively simple. Just like people with myocardial infarction, it was like if people had heart attack, they went to the CCU, they were placed on a heparin drip, and that's all you got. And then it was medical therapy all alone, and with potential diuretic as Lasix, and there was nothing else available. So back in the 1990s, the transplant landscape was simplistic as well. It was essentially if someone was deemed that they have significant heart failure and would be eligible for transplant, there were essentially 2 tiers, that you're either in an ICU requiring some sort of inotrope or some sort of mechanical support, and that's your level 1, and everyone else is level 2. That evolved over the years just with the advent of different medical therapy regimens, more ease and comfort with inotropic support, with milrinone, dobutamine, dopamine, epinephrine, and then really technological evolution in mechanical support. Before we only had balloon pumps, but now we have balloon pump, ECMO, Impellas, total artificial hearts, Centromag LVADs, a lot of different options. And so the systems evolved with it. In the late 90s, more early 2000s, which is what if you ask the seasoned cardiologists who've been around for a long time, and many of you who sort of saw the allocation system before the most recent iteration, it became a little bit more complex, but it was still relatively simplistic. That if someone was in an ICU requiring inotrope or mechanical support, then they would be listed at the highest category, which was 1A. And patients who are on durable support, like an LVAD, who could be at home, they would be essentially 1B. These also included people on inotropes. But if you're on inotropes, irrespective of the dose, irrespective of hemodynamics, if you had a Swan GANs in, you're 1A. So how do you differentiate? Like, I could just put a Swan in because the hospital has a capacity, but the other person, the other hospital is full, or the floor is full, and they can't have a Swan in. So are those 2 people different? Are the acuity different? But this model didn't address that issue. And so I think that was the impetus to really identify, how do we identify patients who has the highest amount of need for an imminent advanced therapy? And how can organ and recipient sort of pairing make that feasible, that part of feasibility? So as you sort of talked about, the motivation for the change was essentially doing that, and also that with technological evolution and innovation, we have all these gadgets in our armamentarium, but are they all the same? Is balloon pump the same as an Impella? Is Impella the same as total artificial heart? Is that the same as being on BioVac Centromags or ECMO? And we know that that's not true, that each of them carry a different degree of risk, and that there needs to be a risk stratification based on. Durable LVADs also has really changed, evolved over time. The HeartMate 2 and HVAD era, where people were in the hospital on heparin drips and being bridged with all these complications of strokes, pump thrombosis. Like HeartMate, please, we don't see that. And so
Dr. Parikh, sorry to interrupt. Your slides are not advancing for us. Whoops. Oh.
You see it? Okay, so this was the old system, if you can see it. Get out of this view.
Okay, we can see it now. Yep.
Okay. I don't know how to get out of this view, but it's okay. Whatever.
Do you guys see notes or do you just see the slides?
We just see the slides.
It's like the
So I
red.
don't know. Yeah,
Oh.
if you advance, hopefully we'll continue to go. So yeah, we just saw that it switched to a new slide now.
Yeah. And then also, so we were just talking about like how technological evolution introduced all these different gadgets and allowed us with the new strata to really help stratify patients based on their acuity. What was happening at the time was because of the mixed bag that status 1A was, that it was just getting bigger and bigger and bigger. And then whoever got listed first would have priority based on timing. So someone on ECMO would be competing with the same person on inotrope with the swan in place who's been in the hospital for 1 month, but that person would get priority over the guy on ECMO. And so how do we address that discordance was the issue. And then also more technological advancement on the donor aspect side with donor preservative systems, organ care systems like transmedics that you have started to hear about now more here with us in the transplant program, that how can we make geographical inequalities and address those issues as well. So that led to a change in the allocation system that is the more contemporary one that transitioned at the end of 2018, around 2019 or so. And so for the individuals who have cards here in the room, you can see we broke it down by statuses, and that's also on here. So to identify people with the highest acuity are the people on mechanical support in the hospital, bedbound, people who are on ECMO and non-dischargeable LVADs, or having complications of mechanical support with life-threatening arrhythmias. Those are the general individuals who are listed status 1. Status 2, even though acute, but it's not the same degree of acuity as status 1's, which includes durable LVADs with complications. Non-dischargeable LVADs, right? Balloon pump. It's an assist device. It's a left ventricular assist device, but you can't discharge someone on it. Impellas or Centromag. Those are the surgical left ventricular assist devices. Or any individuals with ventricular arrhythmias that are not safe for discharge. So many of our patients with hypertrophic cardiomyopathy who've had ventricular fibrillation, who need dual inotropes or dual antiarrhythmics, those are the people who fall into status 2 category. Status 3 category, we don't hear a whole lot about, at least in our general population. There are reasons for which we'll go over. Include people with durable LVADs with some complication, like the driveline infection that's recurrent, or having some pump malfunction related issues, but not at the level of acuity of individuals with status 2, where they have recurrent bacteremias and such. And any people who were initially listed as status 1 or 2, but after a period of observation, if there's an improvement so that they don't meet hemodynamic criteria, they get dropped to 3. And the nuances are not on this screen, but if you flip the card, some of the nuances are that, and we'll go through that in a couple of slides. And so status 1, 2, and 3 now really represented all the patients that were just categorized into this one big bucket, 1A. So that tier system, where it was hard for them to discriminate against the acuity of the patients, it helped us identify it into 3 major buckets for 1, 2, and 3, representing 1A, the previous 1A. Status 4, 5, and 6 are usually the outpatient patients who are listed on transplant. So that represented the 1B category, individuals with congenital heart disease, hypertrophic cardiomyopathy with some arrhythmias and some high filling pressures, but not meeting criteria for them to be in the hospital. And individuals on inotropic support, but they're at home on 0.25 or 0.375 of milrinone. They're fine, they're stable, they're at home. Also, the durable LVAD patients who are at home. But for you on the inpatient side, it's usually the 1, 2, and 3 that we sort of deal with. We also sort of spoke briefly about how did we address the geographical inequalities in transplantation. So historically, there are pockets within the United States that are very sort of transplant-friendly pockets, tend to be more on the West Coast in California. For reasons that are not completely clear, they just had higher proportionate of donor to recipient ratio. So for them, it's not a problem to bring someone from home and offer them transplant, while if you're in the Northeast or really sort of densely populated areas, even in this current schema, as a status 4, 5, and 6, transplanting, forget about it unless you have a favorable blood type or a body size. So to address that, in the previous generation of allocation system, it was essentially restricted to where the recipient is located. So your interactions were primarily with the OPO, or organ procurement officers, and your donor-specific area, which was around 250 sort of nautical miles around the person's located. So for a person in Philadelphia, they'll only get offers from Pennsylvania region. If you're living in Oregon, you would only get it from around the Oregon area. For California, it will only be California. But again, with improvement in technology with organ care systems, where we are able to travel and preserve the hearts ex vivo, that in order to also address the inequalities of different pockets, this more organ care, organ sharing proposal was placed. The coastal regions were also at some degree of disadvantage, right? Because if you're sort of just looking at someone who's on the coast, like New York, New Jersey, Pennsylvania, or Philadelphia, when we draw a circle around us, well, half the circle is the ocean. So that means we're sort of losing out on that potential territory that we could be receiving offers from. But this organ new allocation systems try to address that, where depending on the acuity, you could actually cross zones. So you're not restricted to donor-specific areas, but you could cross to Zone A and Zone B. Those are defined by different nautical miles. So Zone A represents 500 nautical mile circle. Zone B is about 1,000, and Zone C and D are 2,500 nautical miles. So just to give like an example, like most of our transplants occur within a 500 nautical mile radius. So we're able to essentially, for most of our transplant offers come somewhere along like Illinois, that's like the border on the west, and probably Tennessee and Carolinas down south, with rare and some from Florida as well. But now with Transmedics that we are partnering with, we're able to travel 6 to 8+ hours. And so potentially we could get an ideal match from even longer distances, but again, only if you fall into this sort of zone and scheme. So as you see, like the organ sharing is more prominent in status 1s and 2s, because those are the really more acute patients and you want to find the right match, even though it may be at a distance. So this schema was implemented in 2018, in October 2018, and people started to track to see, well, how did our behavior change and how are we doing in terms of transplantation after this new allocation system? So this was the first data that was published after the change in allocation system in 2022. And on the left, you see individuals with 1A, 1B, and 2, and how it broke down into different tier 1 through 6, the new allocation system. Here you see that most of the transplants were still occurring amongst the highest status patients, 1, 2, 3, and 4, which represented a mix of 1A and 1B. When we looked at our mechanical support experience, it's like, how did we do in terms of mechanical support in terms of the people who were receiving transplants? And what was interesting to see was that when it comes to ECMO, pre-allocation, pre-2018, about 4 to 5% of people who got transplanted were on ECMO. Post-allocation system, now it's 8%. Balloon pumps, which we used frequently when needed, who accounted for about 10 to 13% of patients pre-transplant or pre-allocation. In the new allocation system, that number jumped to 30%. So people started to sort of scratch their head and say, wait a second, it's the same population, it's the same number of people coming cardiogenic shock. Are they just getting sicker that they all need balloon pumps now compared to before? Or there are that many more sicker patients requiring ECMO? And it sort of raises a question to some degree that with the new allocation system, did our behavioral pattern change in terms of what we're doing? And that's why I think being true to the hemodynamics is really important. When we looked at what were the outcomes like on the patients after transplant and during the allocation system change, but we also noted that there was a shift in people who were being transplanted. When we look at, this was also in 2022, the data was published, that majority of our transplants were now occurring only between status 1s and status 2s, which accounted for more than 50% of the transplants compared to 3 and 4. Which made sense in a way because those were the higher acuity patients. But it was interesting to see that within each region, the utilization of balloon pumps and mechanical support devices really sort of changed from before 2018 and after 2018. And this was the more recent publication. This was at the end of 23, beginning of 24, looking at region 9, which is New York, New Jersey, and region 2, which is us, about what is the proportion of individuals receiving transplant and what status are they. So 1A and 1B are the blue and the green and the columns on the left. And the other statuses are different colors, which are represented in the right columns for each of the regions, with status 1 being the dark blue color, people on ECMO, people on non-dischargeable LVADs, ventricular arrhythmias getting shocks. Status 2s, high dose inotropes on mechanical support balloon pump Impalas, versus ventricular arrhythmias on dual antiarrhythmics. And as you can see, that the proportion of people that we saw just a year before was around 55%. That proportion started to increase in region 9 and 2 to upwards of 70%. And in the most contemporary data, which is not published yet, when we look at just within regions, the region that we live in the Northeast, I would say about 80% of transplants occur for individuals who are status 1s or 2s. Yeah, I think it reflects the change in practice, and we addressed one set of concern regarding the bloating of status 1A, and now what's happening is bloating of status 1 or status 1s and 2s across the country. And I anticipate another amendment for the allocation system to come out in the very near future to really help learn from the experience over the past 5+ years or so, and to see whether can we risk stratify even more in the status 1s and 2s to really identify people who are in imminent need versus someone on a stable platform, balloon pump versus Impella versus biventricular endovascular support devices. It's a little bit small here, but you guys have the cards here. Can you see the slide okay on the screen? So
yes, we can see them.
Yeah, so these are the hemodynamic criteria that helps us identify and differentiate and discriminate against who is the person who's more, who's sicker compared to another counterpart. And the justification for status 1 and 2, the hemodynamic criteria are very similar. It incorporates your daily sort of SWAN numbers and their blood pressures to see if they're able to maintain adequate perfusion, adequate decongestion, and then end organ function. So for individuals who have poor perfusion, someone who's hypotensive, who has end organ dysfunction, and is mounting evidence of increased congestion, low output, those people would benefit from one, augmentation of support in the form of inotropic support or mechanical support. The way the listing works is that if within 7 days prior to escalation of support, whether it's inotropes or mechanical support, in this case, primarily mechanical support, an individual must demonstrate 4 of these criteria: that they have to have a systolic blood pressure less than 90, a marker of perfusion, cardiac index less than 1.8 if they're not on any inotropes. But if they're on inotropes, it has to be less than 2. And other markers of end organ dysfunction, which is systolic blood pressure less than 70 or hypoperfusion with lactate greater than 4 or LFT abnormalities. Those people would qualify to be qualified for escalation of support, impellers, balloon pumps, whatever. And then the marker of congestion, which I forgot to mention, which was pulmonary capillary pressure, wedge pressure greater than 15. So you have to meet all of these criteria within a 24-hour period in 7 days prior to justify the need for escalation of support. And if the escalation of support is required because of univentricular problem, our choices are usually balloon pump or impellers, because they are left ventricular assist devices. But for individuals who have biventricular dysfunction or arrhythmias, then they need biventricular support. And many programs have different options. For our program, it's usually via ECMO, because we don't tend to use RV impellers or RV flex as frequently due to complications that are associated with and limited issues with that. But these are the numbers that we are often sort of are assessing for on your daily hemodynamics to do that. Now, when someone is listed and escalated to mechanical support and upgraded to status 1 or 2, that's not the end all be all. We have to really continue to work towards optimization and then demonstrate at a certain interval, 7 days for status 1 and 14 days for status 2, that we are unable to wean that support. And that's why oftentimes you have those sort of, every two weeks you have to get a right heart cath. Because on right heart cath, what we're looking for is that are they adequately supported, and what would happen if we wean support? And weaning support means mechanical support. So if we turn down the impeller from P8 to P6 to P4, are we inadequately supporting them? Are they becoming hypotensive, which is your MAPS dropping less than 70 or systolic blood pressure less than 90? Are you becoming more congested? Is your wedge pressure starting to rise over 15 despite being on inotropic support and MCS? Or you're demonstrating markers of poor perfusion because you're weaning mechanical support and they're just dependent on it. So if your cardiac index is less than 2. If that's the case on a right heart cath in the cath lab, then that justifies us to extend the period for another 2 weeks. And then again, we have to re-establish that weaning protocol. If the right heart cath just demonstrates the wedge is 25, well, there's no weaning needed. For some people, the wedge is like 14, in which case what we would do is leave the swan and they come up to the floor, and then you go from P8 to P6 to P4, and to see if the hemodynamics are adequate, or are we seeing a rise in wedge, a drop in blood pressure, or drop in cardiac index, in which case they're not tolerating the wean, and we can justify continuation of status 2 for those individuals at that level. That's why the need for the every 2 weeks right heart cath for these people. And then the other component was the arrhythmia component. So I know you've taken care of many people with individuals with ARVC, HCM, who come in and they're having so much ectopy, amiodarone drips, lido drips. And it's like, we cannot sustain this, and they have to wait for weeks on end here with the tele going off. But the criteria for us to escalate and justify listing in a higher status for ventricular arrhythmias is that not only having just frequent runs of VT, and not only getting device therapies in form of ATP that is able to get them out, that one, you have to have contraindication that you cannot do more than medical therapy, that they cannot just get an ablation. Two, they must have at least 3 or more episodes of VT and VF. So we actually have to make people sicker before they can get better. And also uncomfortable, that they have to have that within a 24-hour period, separated by an hour. And individuals must receive ICD shocks or external cardioversions to really justify 3 or more.
In 24 hours?
In 24 hours. On dual inotropes with normal electrolytes to really justify and say this person is just that sick.
But how come when they sit here, they seem fine because we're on lidocaine and stuff and they don't have any arrhythmias?
Yeah.
That's all for arrhythmias?
That's, no, this is on antiarrhythmics. To really justify a 1 or a 2. And sometimes we have to write an exception because it reviews that and then they give us approval. It's a possibility that they may say no, in which case we say we've tried and you go home. So those are the criteria for 1s and 2s. And on the next slide is criteria for 3. Those are the 3 statuses that are inpatient. Those are the people that you sort of interact with. The 4, 5, and 6 are at home. But also for status 7 are individuals, or status 3 rather, are individuals who are on mechanical support for 1 week on ECMO or 2 weeks on impeller support or balloon pump support, but then they don't meet hemodynamic criteria. In which case, if we cannot justify that, then they automatically drop to status 3.
Even with an impeller?
Even with an impeller. If they don't have the hemodynamics, they drop to 3. And in our region, it becomes a bit of a challenge because if 80% of the transplants are occurring as status 1s or 2s, especially for the non-favorable blood type, which is the blood type O, the most common one, it might as well be here for 6 months. So it becomes a challenge. But we have to abide by some of these sort of guidance and criteria to justify the acuity and the need for the person to be in that status. Then these are the inotropic doses that justify status 3 criteria, which is dobutamine 7.5, milrinone of 0.5, or if you're on multi inotropic support agents.
So do the 3s have to keep the swan in?
So if you look right over here, must maintain Swan-Ganz catheter or daily hemodynamic monitoring.
That's the killer.
Yeah.
Keeping these swans in for
Yeah.
forever.
Because in the board, like when you're risk stratifying patients, okay, fine, they're on high dose inotropes, but if they're stable, that they don't need daily monitoring, hemodynamic monitoring, Q6 hours, then they're not sick. They're not sick enough compared to someone who needs that monitoring. It's a tool to get risk stratifying.
I know, but it's also a
Infection
complication.
risk and
Yeah.
thrombosis risk and those things. And so oftentimes where someone is waiting for extended period of times, we'll write to the review by the degree of acuity of that individual to guide what level of listing that we could justify for it. Sometimes we're calling, it's like, what's the blood pressure? Is it 89 yet? It's because of that reason. And when they say less than 90, they really mean less than 90. Or index less than 1.8. If you calculate it, if it's 1.795, but in the flow sheet, if you write 1.8, doesn't matter. And so if the index is 1.7949, write 1.749, because if you write 1.8, when we have to sort of list them, it won't accept it in the form onto UNOS.
Yeah, we've had some doctors start to request that we round to the hundreds, or,
You at least have 2 decimal
Yeah,
points
yeah.
to guide. And one of the reasons, and to do like just a brief talk together, is to help sort of be on the same page and justify why we're asking for the 2 decimal points. Because if it's 1.8, if you write it, it doesn't qualify. Yeah, like on your wedge tracing too, depending on the level, but if you write 15, doesn't count because it's not greater than 15. And so is there, and sort of broader scope, is there really a difference between 14 and 15 or 15 and 16? It doesn't matter. But because of the strict criteria that we have to follow and that OPCAM would allow, those are the numbers that we sort of go by.
I just need to write something.
Yeah. there's a lot of interest in just sort of understanding that in terms of what are the criteria we're looking for what level of listing, what does it mean? Why are we doing every two, blah, blah, and why do we maintain this Swan catheter? So I thought it would be a good idea to just share the true justification requirements of UNOS listing alongside with the structure of the listing, just so that the patients they care for on a daily basis, you understand and a better sort of concept of that as
Thank you. This is really helpful. And sometimes we don't know, we're like, do they want the numbers to look better today or do they want the numbers to look bad?
well. Yeah. I mean, the goal is like, to really sort of use the hemodynamics the way they are to guide our management. And then oftentimes that's why, like, you saw the practice about the balloon pump and ECMO, and that's not the purpose of these things. The purpose of this was to identify patients who will benefit from the most. Because even if we look at in our microsphere with just pen alone, we have several, in the current state, we have 8 patients listed as status 2. But all of those 8 people are not the same. And so we have to really see what the hemodynamics are and guide the acuity of that particular patient and see which one is sicker than the other one. And now you sort of do it on a macro basis with the region and then the country. We have to really be true to the hemodynamics and use that as a guidance, because if it's a slippery slope otherwise, because then otherwise you're doing a disservice to another patient who's also your patient.
Question about the hemos.
Mhm.
We have had patients where we've exercised them beforehand. Where does that fall into this when it comes to, are these resting hemos? Are these?
Yeah, these are resting hemos, unless someone has an abnormality, like someone with an ASD, where you know that you're being left to right shunt, where your true like standard protocol hemodynamics with the mixed venous through the Swan just cannot be done, but we have to make exception and do from that, that it has to be done. The exercise hemodynamics we often use, like if you don't have regular criteria for it, but we know that the person is symptomatic despite that, and there is no safe plan for them to be off of it, then we would use a combination of that and exercise ones to write to the review board and say that with activity, with this amount of activity, their hemodynamics completely fall apart. And falling apart is not something that we say, oh, they fell apart. This is what happens with X amount of activity, and these are the hemodynamics. And would you allow us an exception to maintain the status or list them at a status, given that at rest, which is, again, more of a snapshot, that they don't meet the strict criteria. And the patient doesn't follow this really sort of nice laid out buckets, but it's just a little bit outside of the bucket. But with effort, there's no reserve in this individual, and that their acuity is probably resembling patient status 2. Would you allow us status 2 listing exception for them? It's more to present to the review board and see if they would allow it.
Okay.
Yeah. But in general term, these are resting hemodynamics. And again, another question is, and again, that's where the nuances come into play. Here, when we do resting hemodynamics, you allow them to sit down, lay down for 30 minutes, and we do that, right? Depending on what time you give medication, the outflow load's different. If you go in the cath lab, now you've got fentanyl burst, your hemodynamics are very different in the cath lab compared to here. So unfortunately, there's no way to risk stratify and understand all the nuances of it, and we stay true to it as best as possible, recognizing that whenever the hemodynamics are obtained from one individual to the other, there may be a lot of variability of other factors there's no way to control. Because one cath lab would never give sedation. Like, so when we did radar cath in my previous institution, we would just do local lidocaine. But in our cath lab, it's a protocol, fentanyl versed before any cath. And so your preload, your afterload, your adrenaline requirement, they're all different. And so, but we stay true to what the numbers are to guide us, essentially.
Thank you.
Cool.
That's nice.
Yeah.
So we'll share, like, I guess for people who are not here too, we'll leave these here, or some of it leaves here. If it's helpful, just for as a refresher from time to time, or having one of these in the workrooms or workstation areas, whatever it's.
Yeah, absolutely. Can we keep that whole stack?
Yeah, it's totally yours. And
Well, okay.
we're working on getting them
Yeah, we
smaller.
wanted them into like a pocket card. It just turned out to be this big.
So
Yeah, there's
a lot of words to fit on. There's a lot. But yeah, so when we get the smaller ones, we'll also make sure that these get delivered. But yeah, please take that stack. Yeah.
Thank you very much.
Yeah, so these are the same criteria. So if you actually go on to Google and if you just
Okay.
type in hard allocation
Okay.
listing criteria, there's a big PDF document that goes through not only the criteria